We've all seen it happen, right? A brilliant new idea, maybe some cutting-edge strategy, something totally evidence-based, gets rolled out with all this hope, and then just hope. Oh, you watch it just slowly, kind of quietly fade away, poof, gone. Why does that happen? I mean, we're swimming in information these days. We're pretty good at knowing what we should do, but we often miss that crucial piece, the understanding of why things actually stick, or, more often, why they just don't. So today, we're going to put on our detective hats. We're diving deep into exactly that question. We're looking at the sustainability of an outcome measure in outpatient stroke rehabilitation. And we're pulling insights from some really rigorous research here, what's called a realist evaluation. It really gets into the nitty-gritty, the core mechanisms of how change actually lasts. Think of it like peeling an onion, trying to understand not just if something worked, but how it worked, and crucially, why it endured.
Yeah, and it's probably good to just set the stage here. When we talk about sustainment in this context, what do we really mean? Because it's a lot more than just people continuing to use something. It's about continued use, sure, but also financial viability, continued capacity to actually do it, continued evolution or adaptation as things change, and maybe most importantly, continued benefits. Benefits for the individuals, for the organizations, and the whole system. And the fascinating part is all these things are totally interlinked. It's like an ecosystem.
Right. So our mission for this deep dive is pretty clear then. We want to figure out how, the underlying mechanics of it all and in what circumstances these specific contexts, this new rehabilitation outcome measure was sustained, or maybe why it wasn't sustained in some ways. And we think there are some, surprising facts and definitely some practical takeaways here for you, the listener, whether you're actually in healthcare or just kind of curious about what makes change last. Because even though this study focuses on stroke rehab, the principles, they feel pretty universal. So yeah, pay attention. This could be useful for you. Okay, let's unpack this core problem. We put so much energy into implementing new stuff, new practices, but the real uphill battle often is keeping them going, sustaining them. It's like building this amazing sandcastle, and whoosh, the tide comes in. And this is where the study gets really interesting, right? Getting to the core of why those great ideas just fizzle out.
It is. And the reality is, it's quite stark, actually. If you look at systematic reviews, they suggest clinical practices are only sustained, maybe 40 to 60% of the time in healthcare generally.
40 to 60,
yeah.
Wow.
And a recent realist review we did found a similar rate, specifically in rehabilitation. It was holding steady around like 54%. So it's definitely not a sure thing that a good idea will stick around.
And the knock-on effects of that, of poor sustainment, they're pretty significant, aren't they?
Oh, huge.
You're talking wasted research funding, obviously, lost potential improvements in care quality, patient outcomes, and hits morale too, right? Clinical partners get discouraged, less enthusiastic about trying the next new thing. It's kind of a vicious cycle.
Exactly. Now, the specific thing they were looking at in the study, the measure, it's called the Mayo-Portland Adaptability Inventory version 4, or MPAI-4 for short. It's basically a tool used to assess things like impairment, activity limitations, participation restrictions after a stroke, during rehabilitation. And, this is crucial, its use was actually mandated by the Canadian province of Quebec. So it wasn't like, oh, this is a nice idea, let's try it. It was required.
Okay, and the study's approach, this realist evaluation, using a mixed method single case study. That sounds fancy, but it's quite clever, isn't it? It's not just asking if something works, but how it works. They're actively hunting for these things they call context mechanism outcome configurations, or CMOCs, which sounds complicated, but maybe think of them like, I don't know, recipes for change. If you have this context ingredient and you apply this strategy action, it triggers this mechanism reaction, leading to this outcome result. They're basically trying to reverse engineer why things succeed or fail. So what did these research detectives actually find? They dug up 18 specific explanations, these CMOCs, but these kind of boiled down into 4 major overarching patterns that really explain the mystery of MPIO4 sustainability.
Right. And the first big pattern they highlighted was that implementation and sustainability, they're not really separate steps in a sequence. They're deeply interconnected, they overlap. So factors that you develop are things you achieve during that initial setup phase. They often just continue right on into the long-term sustainment phase. For example, one specific finding, CMO C5, they called it, showed this perfectly. If a clinical team already had a positive attitude towards research evidence, that's the context bit. And then you had a passionate clinical champion who really stepped up to lead, that's the strategy. Well, that person's drive and their ownership of it, the mechanism that led directly to the MPAI-4 being used consistently, as intended, that's the outcome. And there was this great quote from a manager describing how the clinical champion, quote, had to work overtime and overdrive right at the beginning. But then later, a care coordinator noted that the, quote, culture of measurement in the site is well established. So that really shows how those initial pushes and the underlying culture just carry right through.
That's fascinating. So it's not just about getting started. It's about starting right, laying that groundwork. It makes me think about, trying to start a new healthy habit, like maybe meditating every day, the effort you put in up front, setting up your space, finding the right app, building that initial routine. That's your implementation. But what this research is showing is that initial effort, that foundation you lay, that's what really predicts if it sticks long term. It's all connected, isn't it?
It really is. You can't just draw a line between the two.
Okay, moving on to the second really powerful insight. They found that sustainment isn't just a straight path. It's more like maybe a spiral, with outcomes building on each other recursively.
Exactly. Recursively. That means it's not just a one-way street from A B to C. Think of it more like a feedback loop. An outcome from one part of the process, it doesn't just stop there. It actually circles back and becomes a new input. It might become the context for the next step or a strategy or even part of the mechanism. It's constantly building on itself. And what's really critical here, the study emphasized the central role of patient benefits. That was like the keystone outcome. If the practice doesn't ultimately genuinely benefit patients, long-term sustainment is just, well, highly unlikely. They saw this really clearly in one CMOC, number 14, I think it was. Managers would continue to use the MPAI-4 for evaluating their programs. That's the outcome. Because they perceived it as valuable. That's the mechanism. If, and this is the key context, if the clinicians were actually applying the MPAI-4 information in their clinical decision-making, supported by database interpretations, the strategy, and one manager put it really bluntly, saying, I would drop it if it's not giving me anything, or if it's giving me data but it's not helping the clinical team with patients.
Right, so the ultimate why behind keeping something going is, does it actually deliver value to the end user? Or in this case, the patient. It's like a new software update on your phone, maybe. You'll keep using the new features if they genuinely make your life easier or add something cool. But if it just creates more hassle or crashes all the time, you'll probably ditch it or find a workaround. This really drives home that benefit, that value. That's the ultimate driver for making things stick.
Absolutely. Without that perceived value, it's just not sustainable.
Okay, this brings us to what I thought was a really crucial aha moment from the study. Third pattern. Sustainment is achieved at varying levels across different outcomes, which basically means just because we say something is sustained doesn't mean it's fully baked in or working perfectly across everything it's supposed to do. Sustainment exists on a spectrum, right? It's not just a simple yes or no.
This is a really, really important point. And the data they collected paints such a vivid picture of this. What they found was this striking difference. On one hand, the MPA-4 scoring just filling out the form that was incredibly high, almost universal compliance. Patient chart data showed scoring matched eligibility somewhere between 75 to almost 79% of the time, and they even used that visual analog scale you mentioned, like a slider from 0 to 100. The mean score for scoring behavior was over 63%, pretty high. Self-reported scoring was a median of 4 on a 5-point scale, so people were doing the scoring. However, and this is the kicker, the actual application of that MPI-4 data to clinical decision-making. Shockingly low. Like in patient charts, it showed up as being applied to decision-making only 3.7% of the time.
3.7%.
Yeah, and get this. Only once in the entire study period was it documented as supporting an actual treatment decision. Once. The VAS score for application was way down at 31% mean. And self-reported application was a median of 1 out of 5.
Wow, okay, that is a fascinating and, yeah, frankly, pretty stark difference. So why? Why do we see such high compliance with the scoring part, but such incredibly low actual use of the information? What's going on there?
Well, it seems to boil down to a couple of key things based on their CMOCs. For the high scoring, well, that provincial mandate played a really strong role. CMOC 4 explained this. Even if clinicians privately doubted its value, they had to do it. One clinician, Clinician 1, captured this perfectly. They said, quote, "To me, the MPAI-4 is still a waste of time. It's just because I have to."
Just tick in the box.
Exactly. And when asked, what if the mandate was removed, the response was 100% yeah, they would stop using it. So that really highlights the difference between just compliance and genuine buy-in or adoption. Now, for the low application, the issue that came through loud and clear, particularly in CMOC 12, was trust. or lack thereof. Clinicians just weren't confident in the interpretations that were being provided by the database system linked to the MPI-4. Clinician 4 voiced this really well, asking the MPI-4 is not so precise. Why use it? Then it's not accurate. How do we interpret the MPI-4 in this situation? And that really underlines a crucial point. Just having the data isn't nearly enough. People have to trust the data, trust the interpretation for it to actually be applied meaningfully.
That is such a huge insight. It's like you can track your daily steps religiously on your fitness tracker, right? But that doesn't automatically mean you're using that data to actually walk more or change your behavior to improve your fitness. Or maybe like trying to get your kids to eat vegetables. You can put it on their plate. You can mandate it. But if they don't see the value or taste the benefit or trust that it's good for them somehow, it's not going to become a real habit, is it?
Great analogy.
Just having the numbers doesn't translate to real change without that perceived value and that fundamental trust.
Okay, the fourth pattern they found, and maybe this one feels a bit more intuitive, is that the actual work of sustaining the MPAI-4, it's shared. It's spread amongst lots of different stakeholders. It's absolutely a team effort, not just one person's job. It really does take a village, as they say. That's exactly right. They found that the sustained work of multiple groups was essential. We're talking clinicians, sure, but also clinician leaders, managers, researchers, IT specialists, project managers, all playing a part. CMSE 13 gave a good example. When clinicians scored the patients, that's the context, and the database was set up to easily export that data for research, in strategy, then the researchers and the IT specialists could kind of share the workload, the mechanism which led to the anticipated use of the data in research projects, the outcome. And an IT specialist even noted, quote, "We have made the MPAI-4 on the platform so it is self-sustainable. Maintenance that is required is quite low." So their role was crucial for that research outcome. And they also addressed a really common challenge in any long-term initiative, staff turnover. People come and go. But the team actually developed new strategies to handle it. For instance, another finding, CMOC 16, showed how having specific orientation training for new team members, that was the strategy, helped them quickly understand the project, their duties, the mechanism, and that resulted in the team continuing to work together effectively despite people leaving and joining. That was the context leading to the outcome. A researcher commented on this, saying, "Researchers, for the most part, are fairly stable for a few years, but students come and go. There are strategies like training that we can put in place to make everything smooth."
It really shifts your perspective, doesn't it? Turnover, which we often think of purely as a barrier, a problem. It can actually become almost a positive contextual feature if you have the right strategies in place, like that training. New team members just come in and adopt the practice as, normal work, like it's always been done this way. As Clinician 1 apparently noted in another context, CMOC 3, it just becomes part of the job. It's less about convincing them and more about just integrating them into a system that's already running. That's a really neat example of dynamic adaptation.
It is, building that resilience into the system.
Absolutely.
Yeah.
So, okay, that brings us to the really practical bit. How do these powerful insights connect directly to your world listening in? How do these patterns apply to the changes you're trying to make, maybe in your professional life or your organization, or heck, even personal habits? Like, imagine you're trying to get your team to adopt, say, a new project management tool. You can immediately start using these patterns as a lens to figure out why it's either taking off or just sitting there gathering digital dust.
Definitely. And these findings, they're really not just for healthcare settings. They offer what the researchers called a transferable program theory. Think of it like a kind of universal blueprint or maybe a framework for understanding sustainment in all sorts of different contexts. You really can apply this way of thinking to almost any initiative you're trying to make stick for the long haul.
Yeah, and maybe one really key takeaway for you listening is the value they showed in evaluating diverse sustainability outcomes. Not just one thing. And doing it on a continuous scale, like that visual analog scale they used, instead of just a simple binary yes or no. It's not enough to just ask, is it sustained? You need to be asking, okay, to what extent is it sustained and in which specific aspects, like scoring versus application. That really helps you pinpoint exactly what's working well and maybe more importantly, what needs more effort or a different strategy.
Exactly. And those CMOCs themselves, those context mechanism outcome configurations we talked about, they provide a kind of explanatory roadmap. It can really guide discussions within your own team or project about how to perhaps strengthen the outcomes that are already strong and how to improve the ones that are maybe weaker. It gives you a structured way to ask the how and why questions about why things are or maybe aren't truly sticking.
Okay, so to quickly recap the essence of our deep dive today.
Mm.
Sustainment, it's complex, it's deeply interconnected with implementation right from day one.
Yeah.
It seems to be fundamentally driven by perceived benefits, especially for the end user or patient. It definitely varies across different applications or aspects of the practice, not all or nothing. And it absolutely, positively requires a collaborative village of different stakeholders working together. So if we connect all this to the bigger picture,
Yeah, maybe it leaves you with this thought. When you're introducing a new practice or a change, whatever it might be, are you just mandating it? Are you just relying on compliance? Or are you actively working to foster the perceived value and the trust that are so necessary for its deep, meaningful, and ultimately sustainable application? Because understanding those mechanisms, the how things are sustained, that seems absolutely essential if we want to make meaningful improvements that actually last.
so what new practice or change, maybe in your life or your work, could benefit from looking at it through this kind of realist evaluation lens, something for you to mull over and maybe explore on your own?